What's going on with your patient's cheek? Do you think they might have a malignancy of sorts? Hi, my name's Dr. Anthony Wheeler, and I'm going to tell you everything that you need to know about pathology. Today we're talking about neoplasia. Make sure you have this book, Medical School Pathology and Step 1 Review. It has everything in it that you need to do great on Step 1, and then your medical school coursework specifically for pathology. Neoplasia, let's get into this. Neoplasia means new growth. Neoplasia begins as a single mutated cell, and prior to the onset of the early clinical symptoms, there are about 30 cellular divisions of the neoplastic cell. Neoplasia is not reparative, nor is neoplasia hyperplasia. Neoplasia is the unregulated, irreversible, and monoclonal development of new tissue. For our purposes, neoplasia only contains a single monoclonal isoform. Increased mutations result from each division. Here we have an image from a gastrointestinal surgery showing a colorectal cancer that was removed. Can you point out the cancer? Look at that. You're a budding GI surgeon. Good job. Yeah. This is what it looks like. Let's talk about monoclonality. Monoclonal refers to the fact that the cancerous cells originate from a single abnormal mother cell. Oh, I don't like that, mama. Neoplasia, both benign and malignant, are both monoclonal. Benign tumors are monoclonal, and malignant tumors are monoclonal. The glucose 6-phosphate dehydrogenase enzyme, also known as G6PD, isoforms, can be used to help identify clonality. Multiple isoforms of G6PD exist, such as G6PDA, G6PDB, and G6PDC. Those exist while only one isoform is inherited from each parent. The X chromosome contains G6PD. One isoform is randomly deactivated in each cell via lyonization or X inactivation in females. In cells of any tissue, the normal ratio of active isoforms of G6PD is 1:1. That is, 50% of the cells contain G6PDA, or 50% of the cells include G6PDB. Neoplastic monoclonal cells will comprise 100% of the same specific G6PD isoform. For example, a neoplastic cell will have 100% of cells that contain G6PDA and 0% from G6PDB, or vice versa. Androgen receptor isoforms, which are also found on the X chromosome, can also be used to assess clonality. B cell clonality is controlled by the immunoglobulin light chain phenotype. Chains both heavy and light make up this immunoglobulin. Either a kappa or lambda light chain is expressed by each B cell. The ratio of kappa to lambda light chains of 6:1, or an inversion of that, signifies an malignancy. For example, take these kappa to lambda light chain ratios, for example. A 3:1 would be normal. A 2:1 would be normal. A 4:1 would be normal. 6:1, we'll say that's abnormal. Really, it's borderline. But 25:1, we can go ahead and say that's abnormal. Or if you have an inversion and have more lambda than kappa, That's abnormal for our intents and purposes at this level. If you're a hematopathologist or a hematologist oncologist, right? I'm not talking to you. I'm talking to medical students. Monoclonality. We discussed that, right? And for example, we can see with Mycosis fungoides an example of monoclonality with the T cell receptor gamma gene rearrangements, right? Let's talk a bit about hyperplasia now. Hyperplasia, which is due to polyclonal, meaning that cells are produced from many cells, maintains a 1-to-1 ratio. In polyclonal hyperplasia, the ratio of kappa to lambda light chains is maintained. In regards to tumors, both benign and malignant neoplastic tumors exist. Benign tumors stay confined and do not spread. Malignant tumors may infiltrate locally and spread, i.e. metastasize. For example, let's take a look at this angiosarcoma. Now, this was initially diagnosed as a primary cardiac angiosarcoma. Now, I know there's some radiologists out there that's saying, hey, that is definitely not a heart. And you're right, because we had a malignant condition that metastasized from the heart to the brain. Let's talk a bit about tumors, more of those. If you know what this is, you're probably skilled at Gestalt findings, right? It's a small hemangioma on the scalp of a 2-year-old female. It's benign. Then we may have some pathologic tumors, features of infiltration and pleomorphism and invasion with highly aggressive tumors, such as this mesenchymal chondrosarcoma. For all my budding orthopedic surgeons out there, you'll see this, I guarantee it. Let's talk a little bit about the epidemiology of neoplasia, because this is always asked. The leading causes of death in adults are cardiovascular disease, followed by cancer, and cerebrovascular disease, respectively. Accidental death in children is the most common cause of death, followed by cancer and congenital problems. The information stated is making cancer the second leading cause of death in both adults and children. So by incidence, the 3 most prevalent cancers in the United States of America is breast cancers as first in females and prostate cancer as first in males, followed by lung in both, and thirdly by colorectal cancers. Make sure you know this. You will be asked for sure. The highest causes of adult cancer mortality in the USA is lung cancer, breast cancer in females, and prostate cancer in males, and then colorectal cancer. Make sure you have the proper epidemiology. I believe in you. Early stage cancers will have experienced more divisions and consequently more mutations than cancers that do not manifest symptoms until later in the disease. The prognosis for cancers with late detection is usually poor. The goals of cancer screening are to catch dysplasia before it becomes carcinoma, or to detect carcinoma before clinical symptoms arise. Common screening methods include cervical pap smear, breast examination, breast ultrasound, mammography, low-dose computed tomography for adults 50 to 80 years old with 20 years of smoking history, prostate exams such as a digital rectal examination, or prostate-specific antigen level detection, endoscopy, colonoscopy, and hemoccult test, right? Those are the various modalities of common cancer screening in the United States of America. Cervical dysplasia, or CIN, can develop into cancer and is usually discovered by pap smear. That's why we do screening. With regards to breast examination, breast ultrasound, and mammography, they might identify breast cancer early on, where it can be removed and treated and before it gets to an invasive sort of state, or bad enough where it just starts metastasizing. Mammography can identify carcinoma in situ, such as ductal carcinoma in situ, before it invades, or invasive carcinoma before it becomes clinically palpable. Low-dose CT can be used to detect lung cancer in at-risk individuals, like those individuals with long smoking histories. And a prostate examination and prostate-specific antigen levels, PSA, may help screen for prostate cancer. Regarding cancer screening, we can do endoscopy or colonoscopy and the hemoccult test to detect precancerous lesions in the gastrointestinal tract, such as Barrett's esophagus or tubular adenoma. And in the right here, we see various images of findings for screenings. For example, top left, we see a polyp from a colonoscopy of sorts. And then below that, we see a practitioner of medicine in some aspect giving a breast exam to a patient utilizing high-tech machinery, probably checking to screen for cancer. To the right of that, we see a cervix with no visual lesions that I can see. They sprayed it with acetic acid, and nothing really stands out. Good for them. And above that, in the top right, figure 11, we can see microscopic image of the cervical gland showing an area of high-grade epithelial dysplasia. That's why we screen. This image shows a schematic representation of something that you definitely don't need to know about, so let's skip it, okay? Moving on to carcinogenesis. Don't you love when you get to skip things, right? Guess what? That's not going to be happening too much. I'll give you a little break from time to time, but I'm definitely going to point out the things that you need to know, so make sure you're paying attention, make sure you're sharp. Agents known as carcinogens cause DNA damage, which raises the risk of cancer. Some types of carcinogens include radiation, such as ionizing radiation, oncogenic viruses, such as Epstein-Barr virus, right? And chemicals, such as aflatoxins. With regards to carcinogenesis, damage to the DNA of the cells is what causes cancer to arise. Although the damage is irreparable, it does not cause death. The DNA changes eventually cause major regulatory mechanisms to break down, which enables the promotion, growth, and spread of tumors. Disrupted systems include proto-oncogenes, tumor suppressor genes, and regulators of apoptosis. Now, this image here to the right is pretty critical to know, get a general understanding of what's happening from left to right. We have normal, then hyperplasia, then mild dysplasia, then carcinoma in situ, then invasive cancer. Because tissue can be organized in a continuous spectrum from normal to cancer as more mutations occur. Here's another image showing the progression of carcinogenesis. Cancers and tumors are caused by a series of mutations, and each mutation alters the behavior of the cell somewhat. That's why we screen. We want to catch things early on before they turn to cancer. Regarding oncogenes, cell development and differentiation depend on proto-oncogenes, which are good/normal. And these oncogenes are bad. They are created by these proto-oncogene mutations, which lead to uncontrolled cellular growth. Growth factors, growth factor receptors, signal transducers, nuclear regulators, and cell cycle regulators are all proto-oncogenes that can be mutated and turned into the bad oncogenes that lead to neoplasia. Growth factors like PDGFB in an astrocytoma stimulate cellular growth, whereas growth factor receptors operate as a conduit for the signals produced by growth factors. ERB-B2 or HER2/neu in breast cancer is an illustration of this. Receptor activation is transmitted to the nucleus by signal transducers like RAS. RAS is connected to growth factor receptors while the GDP is inactive. GDP is changed into GTP by receptor binding. Don't we love biochem? Activating RAS. RAS that has been activated signals the nucleus to expand. RAS deactivates by breaking down GTP into GDP, and GTPase activating protein enhances this. However, mutant RAS prevents GTPase activating protein from functioning. RAS remains in its activated state longer as a result, producing more growth signals. And guess what's going to happen if more growth signals are left unchecked? We're going to keep growing. Cell cycle regulators such as cyclin and cyclin-dependent kinase mediate the cell cycle's advancement. Cell cycle regulators come together to form a complex that phosphorylates the proteins needed to move the cell through the cell cycle. For example, the cyclin D CDK4 complex phosphorylates the retinoblastoma protein, which promotes progression through the G/S checkpoint. Here we have a breakdown of how proto-oncogenes can impact a cell in oncogenesis. For the most part, you can have deletion or point mutation in a coding sequence or gene amplification or a chromosomal rearrangement, all leading to more of something happen, whether it's a hyperactive protein that's produced or an overexpression of a normal protein, leading to more progression of a malignant situation. Now let's talk a bit about tumor suppressor genes. As a result of controlling cell proliferation, tumor suppressor genes reduce or suppress the likelihood of developing tumors under normal circumstances, right? Tumor suppressor genes stop tumors from happening, suppress tumor growth. Classic examples of tumor suppressor genes are p53 and retinoblastoma. These genes are like brakes that stop tumor progression from going. Now, since they're brakes, when they're working, they actually stop. But if your brakes are messed up and you try to use the brake, guess what? You're going to keep going because the brake doesn't work. That analogy applies to these tumor suppressor genes when they're malfunctioning or mutated. The development of the cell cycle from G1 to S phase is controlled by p53. When DNA is damaged, it is also the p53 that slows the cell cycle and increases the activity of DNA repair enzymes. When DNA repair is not an option, p53 triggers apoptosis and increases BAX, which interferes with BCL2. Cytochrome C leaks from the mitochondria, activating apoptosis. Both copies of the p53 gene must be knocked out for tumor formation, according to the Canson two-hit hypothesis. In more than 50% of malignancies, loss is visible. With regards to Li-Fraumeni syndrome, the second hit is somatic. Caused by a germline mutation, is characterized by a propensity to develop various forms of sarcomas and carcinomas. Additionally, RB controls the transition from G1 to S phase. The E2F transcription factor, which is required for moving into the S phase, is held by Retinoblastoma. There's an emergency going on. This is real life, folks. We're at the hospital. ETF is released when the cyclin D1 cyclin-dependent kinase 4 or CDK4 complex phosphorylates RB. A RB retinoblastoma mutation causes constitutively free E2F, which permits cells to advance through the cell cycle and expand unchecked. Both copies of RB gene must be knocked out for tumor formation, or Canson two-hit hypothesis. And note that that capital RB in the third bullet point is retinoblastoma. With regards to tumor suppressor genes, unilateral retinoblastoma is the characteristic manifestation of sporadic mutation, where both hits are somatic. Familial retinoblastoma, or second hit, is somatic, is caused by a germline mutation and is characterized by bilateral retinoblastoma and osteosarcoma. This figure here shows tumor suppressor genes and is a model of tumor suppression. We have the Canson two-hit model for tumor suppressor genes, and a haploinsufficiency model for tumor suppressor genes, a dose-responsive model for tumor suppressor genes, and a dose-responsive model for oncogenes. If you remember that tumor suppressor genes are supposed to stop this progression of tumors, and when they're malfunctioning, tumors are going to keep going because they're not suppressed, then you'll be all right. Now let's talk a bit about apoptosis regulation. They stop normal cells from apoptosis but encourage it in mutant cells whose DNA cannot be repaired. Normally, BCL2 prevents the release of cytochrome C by stabilizing the mitochondrial membrane, while cytochrome C can exit the mitochondria and start apoptosis when BCL2 is disrupted. BCL2 is overexpressed in follicular lymphoma. Further stabilization of the mitochondrial membrane prevents apoptosis. Now think about this. If you have a cell or a group of cells where apoptosis is prevented, what's going to happen? Are the cells going to undergo apoptosis? No. They're going to stay alive, become zombies, become mutants, and go on and wreak havoc as they grow into big tumors and malignancies, causing issues. Lymphoma is caused by the accumulation of B cells that would typically undergo apoptosis during somatic hypermutation in the lymph node germinal center. But if BCL2 is disrupted, guess what? Apoptosis is not going to happen. Here we have a little cartoon of apoptosis regulation and some actual cells from top to bottom showing apoptosis. Various cells are involved with apoptosis regulation. It's a complex process. You don't need to know this image. If you're wondering what that thing in the middle though is, I believe it's a dendritic cell. If you're super curious, you can pause and read this here, but you're not going to be asked about it in any way, shape, or form. Other important features of tumor development. Cell Immortality requires telomerase, which often becomes shorter with repeated cell divisions, which finally leads to cellular senescence. Cancers often have upregulated telomerase, which preserves telomeres. For a tumor to survive and grow, new blood vessels must be produced by angiogenesis. So guess what tumors are going to do? They're going to increase things that lead to more vessel growth so that they can stay alive. That's why both the angiogenic factors, FGF and VEGF, are commonly generated by tumor cells. Tumor survival requires avoiding immune surveillance. The production of abnormal proteins, which are expressed in MHC class, is often the outcome of mutations. By down-regulating the expression of MHC class, CD8 positive T cells can avoid immune surveillance and find and kill such altered cells as tumor cells. Cancer risk is increased by primary and secondary immunodeficiency. Here again, we're showing the progression from a normal cell that had an inactivated tumor suppressor gene, eventually leading to cancer. With regards to tumor invasion, accumulation of mutations eventually results in tumor invasion and spread. Typically, E-cadherin and other cellular adhesion molecules keep epithelial tumor cells attached to one another, right? E-cadherin downregulation results in the separation of these connected cells. The basement membranes are destroyed by collagenase when cells connect to laminin. Additionally, in the extracellular matrix, cells bind to fibronectin and localize via spreading. Entrance into vascular or lymphatic spaces allows for metastasis. Now here we see various examples of tumor invasion. All my future breast surgeons out there and future pathologists, future oncologists. Figure 24 on the bottom left shows invasive ductal carcinoma. The middle figure shows invasive ductal carcinoma. This is the surgical specimen that was removed from the patient. The bottom right image shows invasive lobular carcinoma and lobular carcinoma in situ. This is histopathology of invasive lobular carcinoma next to lobular carcinoma in situ. All these are meant to signify that tumors can leave their site of origin and invade and cause havoc on adjacent tissue. Regarding routes of metastasis, carcinomas are generally characterized by lymphatic spread, and local draining lymph nodes first become affected by the spread. That's why we do sentinel lymph node biopsies in certain cases. Sarcomas and certain carcinomas, on the other hand, are characterized by hematogenous spread. Hepatocellular carcinoma frequently invades the hepatic vein, while thyroid follicular carcinoma is another route. Renal cell carcinoma frequently invades the renal vein. The peritoneum is frequently involved in ovarian cancer, which is characterized by the seeding of bodily cavities. This image to the left here shows metastasis to the liver from some other organ of a malignancy. It's likely GI origin. A lot of GI orienting malignancies metastasize to the liver, such as adenocarcinoma of the colon or pancreas, something like that. Let's talk about clinical features of tumors. While malignant tumors are typically rapidly developing, poorly circumscribed, infiltrative, and fixed to nearby tissues and local structures, benign tumors are typically slow-growing, well-defined, distinct, and movable. Before a tumor can be characterized as benign or malignant with absolute certainty, a biopsy is required or an excision is required. That way the pathologist can assess the tissue, both grossly with their microscopes, utilizing molecular tests, cytogenetics, to get an accurate diagnosis. Some benign tumors can develop in a malignant-like manner, and vice versa for some malignant tumors. Let's talk about some general tumors. Tumors may be benign or malignant. Benign tumors are usually well differentiated. Characteristics of benign tumors include organized growth, uniform nuclei, a low NC ratio, a low nuclear to cytoplasmic ratio, minimal mitotic activity, lack of invasion of basement membrane or local tissue, and absence of metastatic potential. Those are characteristics of benign tumors in general. Characteristics of malignant tumors are disorganized development, nuclear pleomorphism, right? The cells look very different. Hyperchromasia, right? Very basophilic or very blue appearing microscopically. High nuclear to cytoplasmic ratio, right? The nucleus is big, the cytoplasm is scant, small, low, high NC ratio. Lots of mitotic activity, right? It's just proliferating at a rapid rate, increased mitotic activity, with strange mitoses, atypical mitosis, and invasion through the basement membrane or into local tissue. Those are features of malignant tumors. Please note that those prior examples and lists represent general tumors. There's always an exception, right? This image here to the right shows pathological features of mesenchymal chondrosarcoma. Wow. Mesenchymal chondrosarcoma of the thigh. Right? Some benign tumors can look malignant, yes, and some malignant tumors can look benign. Metastatic potential is the hallmark of malignancy. Keep this in mind. Benign tumors cannot metastasize. On the other hand, malignant tumors can metastasize. That's a key differentiating takeaway. Tumors that are challenging to categorize on the basis of histology are characterized using immunohistochemistry, among other things. And here we have representative images of various radiologic scans and a tumor of sorts that appears to be very basophilic in areas and contain various cytoplasmic vacuoles, looks epithelioid, right? Be on the lookout for tumors. And what is this? You can pause and check out the descriptions of these images, but for brevity's sake, we're going to move on. Serum tumor markers. Proteins may be released by tumors into the serum. Serum tumor markers may be useful for screening, monitoring response to treatment, and monitoring tumor recurrence. Elevated levels of serum tumor markers require tissue biopsy for diagnosis of carcinoma or what have you. Prostate-specific antigen, PSA, is a serum tumor marker used to screen for prostate cancer. Regarding cancer grading Grading is how bad the cancer looks. A microscopic evaluation of differentiation that includes factors like how much a tumor resembles the tissue in which it develops. Grading takes into account nuclear and architectural characteristics. Low-grade, well-differentiated cells resemble the normal parent tissue. High-grade, on the other hand, poorly differentiated cells do not resemble normal parent tissue. The prognosis of a cancer typically depends on its grade, since well-differentiated tumors have a better prognosis than those that do not in general. And here we have an image showing at the top and bottom various gradings for a particular condition. We have a pontine glioma at the top and bottom, but can you guess which one is high grade? If you're pointing at the bottom, claps to you. You got this. You understand grading. Staging, cancer staging. Now, what is that? They're different from grading. Staging is how far the cancer has gotten. The staging of cancer is used to assess the size and spread of a cancer. Cancer stage is the most important prognostic factor. Cancer stage is more important than cancer grade. Stage is more important than grade. Cancer staging is determined following the final surgical removal of the tumor using the tumor necrosis mitosis staging system, the acronym TNM. T for tumor, or the size and or depth of invasion. N for nodes, for regional lymph node spread, which is the second most significant prognostic factor. And M for metastasis, which is the most significant prognostic component overall. This image to the left, the arrow shows carcinoma in situ, the localized to local advancement, all the way to metastasize, right? Wow, we did it. We did it. We did it. We're on a roll. Great job. You made it through. Make sure you understand all of that because it will come up again. We talked about neoplasia, various features, benign versus malignant. You got this. I'm so proud of you. You're so smart. Wow. You're going to do great. Keep up the good work. Keep studying. Make sure you have access to the website. Make sure you have the book and you're using it. Make sure you're paying attention in your classes. You're helping your colleagues, your friends, people in your class. Pay attention. Make the best use of your time. Good luck.